And on July 1st, most Medicaid beneficiaries will transition to this model. We've got some stats for you up here that it's going to be over 1.6 million of the current approximate 2.5 million beneficiaries will transition on July 1st. It's important to know, especially for this particular provider group, that there is still a sizable minority of beneficiaries who will not transition. And a subset of those who will not transition due to the fact they meet certain behavioral health diagnostic criteria or otherwise require services only available in the LME-MCO network. So as you move forward in the transformation space, it's important to recognize that you may be supporting some people who are in a standard plan option, which we'll talk about, and you may be supporting other people who remain with your LME-MCO partners now. Both systems will exist simultaneously on July 1st. Under the standard plan option, the department has contracted with 5 health plans, also referenced as PHPs for prepaid health plans. Apparently we can't work in state government without acronyms. And those health plans are identified on the screen. Importantly, 4 of the 5 will have statewide coverage, while Carolina Complete Health will serve regions 3, 4, and 5 on the map to the right. Also importantly, we are launching an unprecedented model, a national model for the tribal option, which is in partnership with our Eastern Band of Cherokee Indians. And the tribal option is available to members of the tribe and will also take effect on July 1st. Next slide. So even those of us who have been doing this a while and thinking about it a while know that there are a lot of terms out there that we all need to keep straight in our heads as we're talking about transformation. And we just wanted to provide a little bit of level setting about some of the terms that I will use throughout this deck. Just to note, because transition of care activities, and those are the activities that I have personal responsibility for, are broader than just our behavioral health provider network and behavioral health beneficiaries. Some of the terms may not be as applicable in your all's particular lexicon as they are in other service areas. So just wanted to acknowledge that. Importantly, when we talk about the concept of North Carolina Medicaid Direct, that's a bit of a newly branded concept, and you may have heard the term. And what we're talking about when we say Medicaid Direct is essentially the service delivery models that exist today before July 1st. And those service delivery models will continue for many Medicaid beneficiaries after July 1st. So when we talk about Medicaid Direct, we're talking about when people remain with the fee-for-service programs they currently receive and with their LME-MCO partners. When we talk about Medicaid managed care, I'm talking about those 5 prepaid health plans, that standard plan option that I mentioned on the slide before. We call them different terms. We will call them health plans or PHPs. You may also hear me say, as I've already said, standard plan or standard plan option. When we talk about the launch date of these standard plans, we want to make sure people are aware of the different terminologies we're using. We call it you may hear it called Managed Care Launch, or MCL for short. You may hear it referred to as the Managed Care Effective Date. You may hear it referred to as the Standard Plan Effective Date. For all things within this context, we're talking about that July 1st transition. And finally, as you all well know, North Carolina is also conceptualizing and operationalizing the tailored plan option, which will be a comprehensive health plan available for people with significant behavioral health and IDD support needs. That is not the scope of today's discussion, but we certainly acknowledge that that's very much on your all's mind, and we want to recognize that. Next slide. So now we're going to pivot into the concept of transition of care. And just as we work in the department under a broader vision toward a transformation, we also work under a vision for the transition of care design that I'm going to be overviewing today. And that vision is that as beneficiaries move between delivery systems, the department will maintain continuity of care for each beneficiary and minimize burdens on providers during the transition. So I just want to note that when we talk about the transition of care concept, I recognize that transition of care can be have different connotations. In this context, we're aligning our reference to the regulatory references in that transition of care means when a member is transitioning between health plans or service delivery systems. It's not a reference to care transitions or perhaps transitional care management, where a member is discharging from a facility or transitioning between different types of living situations. So we just want to make sure everybody's super clear on what we're talking about when we say transition of care. Next slide. So in North Carolina, we have put our own particular spin on the transition of care model that we are working to operationalize, in that we have different populations that will transition on July 1st, and we have populations that will remain in the Medicaid Direct program now. After July 1st, we will have populations and members who transition between health plans, and we will also have populations that disenroll from those health plans and return to Medicaid Direct. This is for various legislative carve-outs or because of their personal requests based on meeting certain criteria. But it's important to know that as we have worked to conceptualize the transition of care design, we've worked very hard to accommodate the moving parts that are inevitable with this particular transition dynamic, set of transition dynamics. Next slide. So the last piece of introductory information about the transition of care concept is to introduce the concept that transition of care really has two distinct phases in our particular system. When we talk about transition of care at crossover, we're talking about the mass transition, the mass migration that most Medicaid beneficiaries will experience on July 1st. And so that is the focus of today's conversation and today's presentation. We also have a design to accommodate those transitions that occur on an everyday basis after launch. So after launch and moving forward, members will have the opportunity to change plans and will experience more individual transitions at any point in this dynamic. So we want to make sure that the design that we set up also acknowledges and accommodates those transitions. That is not the focus of today's conversation, but we have worked very hard to harmonize the expectations so that the goals and the design intentions of crossover also resonate in the ongoing transition of care activity. Next slide. So we're going to start to pivot into the specifics of this transition that's about to occur on July 1st. And you've probably seen some version of this timeline slide, but it's important to know that we are working within a obviously bigger timeline context over the next several months in order to prepare for managed care launch and immediately after managed care launch. So we are currently in the members' open enrollment period, where members who will be transitioning to a standard plan option have been notified of such, and they are in the process of having the opportunity to select their health plan, to proactively select their health plan. That proactive option will remain available until May 15th, May 14th. And then on May 15th, using a set of algorithms that work to preserve continuity of care, the department will then auto-assign those members who are transitioning to the standard plan option, and they will auto-assign the remaining members who have not proactively selected a plan to a health plan. On 7/1, as I've said several times, those 5 health plans that I mentioned on an earlier slide launch. And then there is a choice period where members can change plans up to September 30th, and in many cases longer. Next slide. So we want to make sure, as a level setting, before we get into the specifics of the transition to care structure, to reinforce the statement I said earlier, where many members that are currently served by the LME-MCO network will remain with the LME-MCO network. And so behavioral health providers, like I mentioned earlier, may very well be serving folks under 2 different service delivery models. This service comparison table provides an overview, a summary overview of the services that are offered both by the standard plan and the LME-MCO, and those services are represented on the left side of the slide. And it also represents or reflects those services that will only be available in the LME-MCO network after July 1st. Next slide. So we're going to now talk about the specific design elements that have been established for transition of care to support member continuity, with working to make sure that the providers who support those members are informed about these design elements so that they can also support members through the process. Next slide. This provides an overview slide of all of the different moving parts that I'll be talking about at some level. Today, we just wanted to acknowledge that transition of care activity is already well underway in preparation for July 1st, and we'll be talking about some of those pre-launch activities in addition to those activities that will occur after. Next slide. The first thing we want to make sure you're aware of, even though we don't expect it to have a significant provider impact, we do want to make sure you're aware of an exercise that the department and our LME-MCO networks are working on to ensure that members who need LME-MCO only services remain with the LME-MCO and do not experience a disruption in service on July 1st. So we are engaging in what we have referred to as a rapid identification process, where those members who have open authorizations for services only available through the LME-MCO are being identified and proactively having eligibility changes to ensure that they remain in their LME-MCO and that they don't experience a service disruption on July 1st. While we do not anticipate this to have an impact on providers, we do want to acknowledge that in some cases, there are services that are only offered through the LME-MCO, but do not require prior authorizations. And I'm going to turn it over to our Alliance colleagues to touch on the Alliance specific guidance related to those providers.
Sure, Trish, this is Christina, and Kathy had asked me to just give a quick overview here. She did ask, Kathy Downs, our Director of Network Operations, did ask me to just announce that the SAIOP and the SACOP providers will be required to submit a spreadsheet of current Medicaid members receiving the services. So the spreadsheets will be emailed to providers, and we will also have them available on our website. In addition, Alliance will be reaching out to providers as well as posting information on our provider news. I hope that information is helpful. As if you're wanting a little bit more, we do have other folks on the line right now as well.
Going to the next slide. So as I start overviewing some of the design dimensions of the transition to care approach, we wanted to make sure to reflect or reiterate those priorities that we are working to advance under this design architecture. And those priorities are really outlined on the left. We want to, above all else, do everything to facilitate uninterrupted service coverage and ensure that continuity of care is maintained. We recognize that a key dimension of this is to ensure quality data transfer. And we'll talk a bit about the data transfer dynamics that are well underway at this point in order to ensure services continue without disruption. Anyone who is engaged in transition activity of any kind knows that clear and organized communication between entities is a critical component of a transition. And so we have been working to ensure that the responsible partners who are responsible for supporting these members through the transition have clear lines of communication and that we have established protocols around these transitions to support that communication. An important point to perhaps reiterate on this particular next priority is that most of the people who will be transitioning over to managed care, the majority of those beneficiaries who will be transitioning to Medicaid managed care may not require a lot of support outside assistance or access to their healthcare provider. As you all well know, many of the Medicaid population are children. Children who use Medicaid for their annual well child visit and maybe a couple of other things a year. But we recognize that even though a lot of our most vulnerable populations are carved out of managed care and will not transition, we do recognize that there is still a subset of the transitioning population that could be characterized as high need. And we want to make sure that we have particularly given particular attention to their transition experience. And so we'll talk about some of the safeguards that have been established related to that. Finally, and this is certainly part of today's effort, is that we know that an empowered an empowered member and provider network, a member community and a provider network are often the best guarantees of an effective and safe transition for our members. So we want to invest in time and energy in making sure that our provider networks have the resources they need, are aware of the training opportunities available. And so we'll talk about that at the end about some of the resources that are available to support providers through this process. Next slide. So we're going to talk next about some of the key dimensions for facilitating uninterrupted service coverage. And we're going to be talking a lot about the prior authorization or the service authorization migration and the related protections. So if you can go to the next slide. So recognizing that in the Medicaid space, the prior authorization concept is a key dimension to ensuring continuity of care, we want to make sure that prior authorizations that are open and opened prior to July 1st transition over to the member's health plan in order to ensure that those service authorizations are honored by the health plan and services are maintained and non-disrupted. It's important to know that our LME-MCOs will continue to process service authorization requests for members enrolled with the LME-MCO up to 11:59 of the day before July 1st. So up to 11:59 on June 30th, providers will continue to submit prior authorizations to the LME-MCO as intended. All open authorizations and recently closed authorizations will be transferred to the member's health plan to ensure continuity of care. I also want to note here that this is, you'll see this reference to 42 CFR Part 2 at the bottom of the slide. No doubt this provider community is very well informed on 42 CFR Part 2. We do want to acknowledge that 42 CFR poses specific considerations for how data are shared. And we'll talk a little bit about some of those workarounds later in the deck and in subsequent trainings. Just to continue the direction of this slide, health plans are required to honor open prior authorizations for services that are covered by the standard plan for up to 90 days after launch, unless the authorization expires sooner. If the health plan terminates an open prior authorization at that 90-day mark, it must issue appeal rights. Next slide. So it's important to know that transition of care requires, in order to have a quality transition experience, it is an inherently interdisciplinary approach. And it requires the collaboration and the subject matter expertise of a lot of different groups, certainly within the Medicaid space, but also within our community groups, our provider networks, our stakeholder groups. And I just say that as a way to launch this slide, because this slide reflects the contributions of behavioral health subject matter experts. And so in addition to the prior authorization safeguards that I mentioned on the last slide, it's important for folks who provide these services to know that outpatient behavioral health services provided by directly enrolled providers, their units will reset to 0 upon launch. Next slide. This slide is admittedly a busy slide. We wanted to provide several different prior authorization scenarios to you in one slide for reference, for a later reference. And we wanted to make sure people are clear on the timing and the direction of different prior authorization requests around July 1st. So to best orient yourself to this slide, the gold line down the middle represents July 1st, that MCL or that managed care effective date. The left side of the slide, under the red, represents what the activity that's occurring when the member is still covered by the LME-MCO. And the right side, commonsensically, indicates the time that the member is covered by the health plan. So in the first scenario, this is aligned with the information I just shared, where a provider submits an auth request prior to managed care effective date, so prior to July 1st, for a member transitioning to a health plan for services covered by both the LME-MCO and the health plan. So if you go back to that earlier slide where all the services were listed, it's a service on the left side of the slide. The LME-MCO authorizes services as clinically indicated, and that authorization will be transferred to health plans as part of the daily prior authorization file transfer I mentioned earlier. Upon July 1st, under scenario 1, like I mentioned earlier, the health plan is required to honor that authorization minimally for the first 90 days unless it otherwise expires sooner. And if the authorization extends beyond 90 days and the health plan chooses to reduce or terminate, it must issue appeal rights. Under scenario 2, and this is really important, a provider submits an authorization request prior to the managed care effective date for a member transitioning to the health plan for service only covered by the LME-MCO. The LME-MCO may process, but the benefit may not be available after July 1st. So it's really important to underscore why we are doing the rapid identification process that I mentioned earlier. And we want to definitely acknowledge that our intention is to reduce the exposure that members may experience through the transition of transitioning and needing a service that is no longer available to them. I do want to acknowledge that the EPSDT benefit does apply to our standard plan partners. And so obviously there would be additional flexibilities available for children covered by the EPSDT protections. Under scenario 3, a provider, the member has already transitioned, and a provider submits a retroactive authorization request for dates prior to July 1st for a member formerly enrolled in an LME-MCO, but now enrolled in a health plan. The LME-MCO may only authorize for the pre-July 1st effective dates. Providers can then resubmit for additional dates of service directly to the health plan. Next slide. So we wanted to make sure that as you all are developing your own operational checklists and internal processes and procedures to support this transition, that you are aware of a couple of key dimensions. Several things that are on this slide will also be discussing or have already discussed, but we wanted to highlight a couple of things at the top in particular. So the first thing to note as you were preparing to support these transitions and as you're preparing your own internal organizational practices, it's important to remember, like I said, many of the members you serve will not transition on July 1st. It's also important to note that we are setting up the architecture in NC Tracks provider portal for a provider to be able to look up a client's future eligibility segment so that you will know, and this will be available in June, those members that are assigned to a health plan. So you'll know which ones are actually transitioning to a health plan and which ones are assigned and which health plan they are assigned or have selected. Just to reinforce, the managed care effective date that we are talking about in this context is July 1st. So we are not talking about those members who will later be impacted by the tailored plan launch. We're not talking about members who are currently enrolled in foster care and may be impacted by a foster care plan later. We're talking about only those members who are standard plan members, and they will all transition on July 1st. It's important, like I've mentioned on the earlier slides, to be clear on what you're submitting and when you're submitting it. So again, the next couple of bullets just reflect and summarize what I've communicated on previous slides. Also want to acknowledge kind of as a preview to some of our member and provider education detail that the transition of care team is establishing or has established a department transition of care webpage. And that page is currently live and available and being updated regularly at this point. And our intention is to cross-link information to help providers know where to go within each individual plan to submit prior authorizations. So that information is available in a couple of places on the department's website, but we will certainly have it available on the transition of care page. Next slide. So as a complete acknowledgement to the incredible work that this provider network no doubt does on a daily basis, and also recognizing that you all don't think about Medicaid all the time, you think about your clients, you're thinking about different dynamics of managing your provider organization. You are not thinking about Medicaid or even transformation on a daily basis. And so we know that life gets busy. Life is certainly busy now, and you all are supporting really vulnerable people oftentimes. We want to make sure that there are some safeguards and kind of some bumpers to help providers go in the right direction with their authorization submissions. So we've established kind of some safeguards or stoplights to assist providers in knowing where to go and to minimize the chance of a prior authorization request being erroneously submitted where it shouldn't be. So the first thing we're doing are things like education, which is why we know that we are doing a lot of training. The LMEMCO partners have been incredibly collaborative, and we're doing a lot of trainings right now. But that is hopefully going to pay off in that you all become more informed on how the process is intended to work and can make decisions and process design decisions within your own organization accordingly. We will also be establishing, in conjunction with all of our UN partners, not just the LMEMCOs, but all other UN partners, banner messages and notifications that indicate that a member may not be visible or found, or that a prior authorization may not be able to be submitted because the member has transitioned into the standard plan. And finally, we are working through call center guidance for our UN partners to ensure that if providers have questions or have calls, that they have an informed call center staff who can assist them in pointing them in the right direction. Next slide. Just want to acknowledge that while we are not spending a lot of time on appeals in this particular presentation, we do want to note that in many dynamics, the adverse determination process and appeal rights will be processed as usual. Members appealing initial service request denials will be instructed on the option to submit a new request to the health plan. So it's important to know that if a member is requesting a service with a date of service after July 1st, that the member will be redirected to the health plan for initial service requests. Importantly, we know that services that are still under a continuation of benefit or maintenance of service extension do need to be continued, and plans are responsible for honoring the continuation of benefit timeline until they can either reassess that member directly or either authorize the service or issue their own appeal rights. Next slide. So this is not an instruction on claims submission. This is not a presentation about provider reimbursement, but we did want to make you aware of a couple of dynamics as they relate to transition of care. So first of all, claims for dates of service prior to the member's standard plan effective date should continue to be submitted to the LME-MCO. Claims for dates of service after the member's standard plan effective date should be submitted to the member's health plan following the applicable health plan's protocol. So we really hope at this point that everybody on the call has engaged with the health plans or has been engaged by the health plans to contract and to become part of those health plan networks. But it's going to be really important to do so over the next several weeks if you haven't already. However, in recognition that, again, there's a lot of moving parts on July 1st, the department has established a transition of care crossover specific safeguard where health plans will treat claims from non-participating providers for dates of service on or after July 1st, equal to that of enrolled providers until the completion of an episode of care or 60 days, whichever is less. So if for whatever reason, a provider is still remaining out of network and provides services to a member now covered by a standard plan, those providers will be treated on par with enrolled providers for the first 60 days after launch. Importantly, there is statutory protections for certain groups of members that extends that transition period beyond 60 days. Next slide. We're about to pivot to a different design component of our transition of care architecture and talk about some of this additional safeguards that we have worked to establish for members, for high need members who will be transitioning to the standard plan option. So as I've said several times at this point, but just want to make sure everybody is clear on it, many members currently served by the LME-MCOs will not transition. And so these are not those folks who are not going to transition. We are wanting to make sure that there are safeguards in place for those high need members who will transition. And if you go to the next slide, we'll start talking about those protections and some of the specific populations that are included in these categories. So importantly, the safeguards that I've mentioned earlier about the data transfer, the prior authorization protections, the out-of-network provider safeguards, all of those will apply to all transitioning members. And so we have safeguards and foundational safeguards in place that apply to everyone who is transitioning. We have also worked with our partners and within our state team to identify a subset of members who are transitioning on July 1st and still have a higher support or are anticipated to have higher support needs, or frankly have an increased reliance on Medicaid, the Medicaid program for their services. This is the group we conceptualize and call the high need group. We also recognize that while these high need members are going to be identified under certain prior authorization designations and certain claims detail designations, We know that life happens in real time, and we want to make sure that all of our transition partners have the opportunity to flag member-specific circumstances that merit individual discussion between the different entities involved in the transition. So we have set up the architecture for our LME/MCO partners and our CCNC partners and our standard plan partners to identify members who warrant a conversation, a clinical briefing about a particular member. We recognize that there are dynamics that cannot be fully reflected on a PA or reflected in a claim. We recognize there are dynamics that are happening in rapid time, things like an imminent loss of housing, a particular domestic dynamic. We want to make sure that there is a channel for communicating those really important, very time-sensitive dynamics. And so in doing so, we have established what we reference the warm handoff population. Next slide. So this slide reflects a summary of those high need members, those high need member populations that we will be paying particularly close attention to after the transition on July 1st. As you can see, there are a number of different populations represented. Just as a reminder, because the transformation effort is across the board within the Medicaid population, many of our high need members aren't necessarily folks that are actively engaged with the LME/MCO at this time, but they all represent member subsets that have particular clinical complexities or vulnerabilities that have been identified by the department. We wanted to identify a couple of really important ones for this particular provider group, in that we will be flagging members that have experienced crisis behavioral health services within the last 6 months, but have not otherwise been identified as tailored plan eligible. We will be identifying those as high need members. We will also be identifying members who could remain in the LME/MCO, often referred to as standard plan exempt or tailored plan eligible, and those members who have proactively chosen to transition to one of the 5 health plans. So someone who would have the eligibility to remain with the LME/MCO on July 1st, but for whatever reason has selected to proactively pick one of those 5 health plans. That particular member population, that member subset, is considered a high need population simply because of their tailored plan eligibility. Health plans are then responsible for triaging those members and providing rapid follow-up to all members who are assigned to this health plan's high need priority group. And that rapid follow-up requires a human contact. It's not a letter, it's not an email, and it's not a call that didn't actually occur or a call that wasn't actually taken. It is a goal to make sure that every single member in this population has human contact with that health plan to make sure that services have been maintained and that members are clear about how their services will be supported moving forward. Just as a note that's not fully reflected on this slide, the department will also be doing look-back survey sampling of this particular population and logging the experience that that member has had and communicating issues to the plans directly. So again, we're working really hard to make sure that we have a concentrated effort at every level to support these particular members through the transition. Next slide. We do not anticipate that the high need engagement or the warm handoff process that I've mentioned will have a direct impact on providers. These conversations will be occurring between the LME/MCOs and the health plans. However, oftentimes no one knows a member better than her provider network. And so it is very possible that LME/MCOs may be reaching out to providers, specific providers, or reaching out to their provider network as they work to identify these particular members. We also want to note that if a warm handoff session is impacted by 42 CFR Part 2, and that it is imperative that substance use disorder information be shared and communicated, LME MCOs may be reaching out to applicable providers to assist in securing consent for that communication to occur. Next slide. So once again, we're going to pivot to a different dimension of our transition of care design and talk at a high level about some of the data transfer activity that is currently underway and will, or is soon launching, is soon launching and will continue for the duration, not only of crossover, but in an ongoing manner where data are transferred between service delivery models to sustain and to support member continuity of care as members transition between the health plans. Next slide. So just to acknowledge, there are 3 kind of key buckets of data that are being transferred. There's actually more than this, but these are the key high level domains. First of all, the department is working very closely with NC Tracks to ensure that claims detail are transferred and claims history are transferred for members assigned or who have enrolled with a particular health plan. As everybody on this call can appreciate, that claims detail informs risk stratification and other algorithms for how members are engaged and informs the plan on service delivery history that helps give insight into the member's needs. As we've talked a lot about already, we will be operationalizing the transfer of prior authorizations, open and recently closed prior authorizations, again, for the same reason, to not only ensure continuity of care, like I mentioned earlier, but to inform plans about their particular members' service and clinical profile. And finally, we want to make sure that, again, the detail that may not be easily identified in claims and PA, that we have a resource available to support some of that more individualized, more textured clinical detail. And so we are also working with our CCNC network and our LME MCOs to transition additional service detail about identified members. So in the LME MCO space, sorry, I inadvertently muted myself. If a member is identified for a warm handoff by the LME MCO will provide a transition summary page or has the option of providing a service plan. So we want to make sure that there is an additional layer of information provided on those particularly vulnerable dynamics and information that may not readily be available through other data sources. Next slide. So just to acknowledge, we don't anticipate any major lift to providers in most of these cases. We did want to once again acknowledge that 42 CFR Part 2 does become a factor in how LME MCOs can transfer information. And in just a minute, I'm going to highlight some of the intended safeguards we've put in place and the workarounds we've put in place to ensure that members who currently have services covered by 42 CFR Part 2 can experience an undisrupted service experience through the launch. Next slide. So we are now here at that point where we're talking a little bit about 42 CFR Part 2 and its impact on our transition activity. We want to also note that this is not a one and done. We are offering 2 follow-up trainings later this spring, and the dates are there on the right side of the slide. And so we will go into greater detail about this process that I'm just kind of advertising at a high level today. So just know that those trainings will be coming up and you can pick to come to either of them. They will be repeat trainings. So pick a date that works for you and appreciate your joining at least one. So those of you who are aware of 42 CFR Part 2, you all could give this slide better than I could. Transition to care, again, does not dedicate any particular level of expertise on any one subject because our goal is to bring things together in a way that acknowledges all of the different dimensions of a transition. But 42 CFR Part 2 at a high level is the federal regulation reference for how data can be transferred for people who experience substance use disorder. And there are various very, very specific protections related to consent about how data can be transferred. And it is required that if data are covered by under the umbrella of 42 CFR Part 2, that member-specific consent and consent specific to the health plan be secured prior to that data being transferred. So as you can appreciate, ensuring that that member consent is always secured prior to launch was going to be a pretty significant lift and wasn't always going to be guaranteed. So what we have worked to establish is a workaround where authorizations that would be otherwise covered by 42 CFR Part 2, providers will submit those directly to the health plan. And if the service had been authorized under the LMEMCO, that authorization will be honored as if it was part of the data transfer. So we want to recognize that the goal of the data transfer is to ensure continuity of care and to ensure that services can be maintained after the transition. And we want to make sure that we have a safeguard in place for those services that are covered under this particular 42 CFR Part 2 requirement. Like I mentioned, we will be doing another training later this spring, one of two options, and those options and the registration links are now available to you on this slide. Next slide. So we are now pivoting once again to our other design dimension that we've highlighted at a high level, and that is the efforts underway to ensure members and providers are aware of these safeguards and protections that I've outlined today. We want to acknowledge that members will often come to providers first. You all often have the best and most reliable relationship with beneficiaries, and we fully acknowledge that oftentimes beneficiaries will be asking you questions. So we want to make sure you are very clear on how to support members and where to direct people to. We certainly don't expect you to become the subject matter expert on all of the stuff we've talked about, and certainly all of the enrollment and eligibility dynamics that come into play for this particular population. So we want to make sure that, first of all, you understand about the enrollment broker, and we're going to talk about that in a minute, and help people direct people to the enrollment broker if they have questions about selecting a health plan. We also want to strongly encourage providers to finalize their contracting activity with the various health plans and access the health plan contract teams if you haven't otherwise done so, or if health plans haven't otherwise reached out to you. Next slide. So as I mentioned just a second ago, we wanted to highlight several of the resources that are available both to members and available to providers. And so this slide attempts to provide a kind of a one-stop shop for you. And when you get access to this slide deck, these links are hyperlinked. And wanted to make folks aware of the resources that are now available. Just as a personal aside, I have to say, having directly witnessing and participating in the first round of transformation, and having been in the Medicaid space for some years, to me, the department has invested supports and has invested time, energy, and supports in ensuring quality communication and resources are available in an unprecedented way. So if you are used to perhaps the Medicaid webpage of old, I strongly encourage you to go and check out these resources. I think you will be pleasantly surprised by the value you will find in them. So the first resource listed on the page is the enrollment broker resource. And this is probably a concept that this group is very well informed about, but essentially it serves as the members' resource for selecting a health plan, to get information about the different health plan options, and to get guidance on whether they are enrolled or not. So again, there are other supplemental resources available. It is not the only resource, but we do want to make sure everybody is aware of this incredibly important resource through this enrollment experience. Secondly, the department has launched the North Carolina Medicaid Beneficiary Portal, which is broader than just Medicaid transformation. It's all Medicaid activity, but it's a really important, very user-friendly resource about Medicaid, and it's very beneficiary facing. So we encourage folks to take a look at it and make sure and help members know that it exists. The third resource is much more provider facing, although it's certainly open to everyone, and that's the Medicaid Help Center. And the Help Center is a newly launched platform. So we strongly encourage people to be aware of it. And I refer to it as Medicaid Google. So you can go on this website and there is a literal search box where you can Google whatever question you have about Medicaid or Medicaid transformation. And in many cases, and in growing number of cases, receive very specific knowledge articles or FAQs on your specific subject. So that portal, obviously the information in it continues to grow daily. So it's always being refreshed, and it is managed by a very well managed, very well organized group of people who ensure that your questions will be answered in very prompt fashion. So we really encourage people to use this resource if you haven't otherwise used it before. The next resource on this page is related to the department's transformation website. So you all are probably familiar with it, but we often shorthand this reference to be the provider playbook. It is very provider facing, and it does include a wealth of information about a number of really, really important topics that I'll highlight here in just a minute. The final bullet here, it kind of gets swallowed on the page, but I just want to make sure people are very aware of it. As we near launch, it is going to be critical that providers understand and are aware of the health plan's own resources, because those resources are what becomes most relevant on July 1st. And so we want to make sure people are aware those resources exist and know where to go to get additional information. Next slide. This is a little bit of an aside, but we want to make sure people are aware of this resource that exists for members. We know that members having access to transportation to get to their appointments is a critical dimension of making sure service continuity is preserved. And we have worked with our health plans to ensure that they are part of the solution of making sure that members' non-emergency medical transportation maintains and continues without disruption after July 1st. So there are a number of ways that we are safeguarding this particularly important service. And there are a number of safeguards related to data transfer and collaborations with our DSSs to ensure that health plans are informed of members' NEMT histories and experiences. But we also want to make sure that members are empowered to help schedule their own visits. And so we wanted to alert folks that starting June 1st, a member can call the health plan directly to schedule to schedule transportation for appointments occurring after July 1st. So prior to July 1st, for appointments occurring prior to July 1st, the member will continue to call the DSS. But on June 1st, if a member has a transportation need for an appointment after July 1st, the health plans are prepared and available to assist in scheduling those. Next slide. You can go to the next slide. That one is repeated. I've mentioned the transition of care webpage a couple of times earlier in the deck, and I did want to bring it to your attention. that this page is live, and we recognize that transition of care is an inherently interdisciplinary dynamic, and it's also a time-limited dynamic. So we know that the information that you need on July 1st, it needs to be rapidly available and easily bookmarked. And so there's so many good resources out there on the website and in general that we're going to use the transition of care page to highlight some critical aspects that are already available in other areas, but that we want to make sure you have kind of a one-stop shop in your information. So we are currently populating the transition of care webpage with information, and you can continue to check it for updates and additional links. Next slide. Like I mentioned earlier when I was talking about the prior authorization, transmission, and submission processes, we are really trying to create an educated provider force or provider network at every turn. And like I mentioned, on our UM vendors will be having banner messages similar to the one that's sampled on the page here that helps inform providers about the prior authorization submission and making sure that providers don't submit prior authorization requests to the wrong place. Next slide. Like I mentioned, we have other resources to support members through the transition that are available on our transition of care page, including member-facing fact sheets. We have worked very closely with our member engagement team to create resources to support members through the transition process. And so there are member-facing fact sheets about the transition and information in one page of who to call if they have a question. So we encourage you to go to the Transition of Care webpage to see those links and know that more links and more information will be populated over the next several weeks. I keep mentioning the provider playbook. I did want to make sure you had this hyperlink specifically in long form in case it didn't come through on the posted version of this deck. And again, this is a Medicaid transformation specific resource for providers, and it contains incredibly important information. Now, if you want to go to the next slide. I want to highlight a couple of specific details that are available on this webpage. First of all, there are fact sheets about what providers need to prepare prior to launch and what they need to know after launch. And a number of the transition of care activities that I've mentioned today are embedded in those particular fact sheets. I also want to bring your attention to the claims and prior authorization reference, because there is a fact sheet out there that provides health plan specific detail about how claims will be submitted and how prior authorizations will be submitted. It is a really important reference for you to bookmark, print out, whatever is your preferred way of holding on good information. But please be aware that this resource exists and it's updated and refreshed regularly. Next slide. The final slide that I'm going to talk through before we turn it over to our Alliance colleagues and we open it up for questions, is one dimension of work that will start on July 1st that is not specific to crossover, but we know it will happen quickly and we want you to be aware of it. And just as important to say, more information to come. But we recognize that starting July 1st moving forward, there will be people who are in the standard plan who require services that are only available through the LME-MCO. And those may be members who transition to the standard plan and need to come back to the LME-MCO and perhaps didn't need services prior to launch, but do now. Or frankly, they may be newly enrolled Medicaid beneficiaries who enrolled with the standard plan and then later experienced a crisis or had some other indicator of needing tailored plan only services. So we want to make sure that as providers, you all are aware that the process that is currently in place that allows members to request to remain with the LME-MCO is being reconfigured to process to enable members who need to return to the LME-MCO to do so after July 1st. And so you will see more information about a process that is going to be probably rebranded as a request to transition or a request to move. And there will be various aspects of that process that will help providers ensure that a member is accessing LME-MCO services as quickly and as efficiently as possible. We are working with our LME-MCO partners and our health plan partners to establish the process and protocols needed to support that these members also have an effective and a safe transition back to the LME-MCO for those members who transition after July 1st. So more information to come on this. We know that at this point, everybody's very focused on getting to July 1st, but we do want you to be aware of it because this is a potential resource to you immediately after launch. Next slide. And with that, I'm going to turn it back over to Christina for any Alliance-specific comments, and then we'll open it up for questions.
Sure, thanks, Trish. And it does not look like we have any questions in the chat right now. I am monitoring it. I'm not seeing any coming through right now. But just wanted folks to know they can email questions. We do have an email address set up here at Alliance. Please feel free to email us here at medicaidtransformation@alliancehealthplan.org. You can email the questions there, and we do have folks monitoring that inbox. So please send questions there. And then also additional information regarding Medicaid transformation can be found on our webpage at the link below. So hopefully folks can capture that link there. We also plan to post the live recordings of today's session. There's a duplicate session that will also occur on May 13th that will have the same information as today. Those webinars will be posted on our website along with this PowerPoint. And this is a great page to check out here, the Alliance Health Plan Medicaid Transformation page. So that is all I have right now, Trish. I'm not seeing any questions in the chat box right now.
Awesome.
Okay.
Well, again, thank you all for your time, and thank you so much to the Alliance team for your collaboration in bringing this together. We look forward to continue our working together as we move toward this this historic transition on July 1st, and appreciate everybody's partnership in doing so effectively.
Hey, Trish. Oh, Trish, we did have one question that just came through. Sorry, did somebody say something?
No, this was Sherry. I was just going to say a question popped up.
Yeah, it just literally just did as we were about to sign off. I see it there. It looks like this one is coming in from Maryland. And the question is, for some reason, I'm getting a lot of feedback. I don't know why. It just suddenly started. Huh, okay. It said, did I understand that if someone has both Medicaid and Medicare, they would be in the tailored plan?
So let me clarify that. People who are currently dually eligible will not transition to the standard plan option on July 1st. If a person receives Medicare and Medicaid and are dually eligible, they are carved out and will not transition to a standard plan on July 1st. Period, new sentence. We know that a number of people who are dually eligible may enroll in the tailored plan later, but the two concepts are disconnected, they're distinct. There's a lot of Medicare dually eligible people who will not be eligible for tailored plan, and they will remain in Medicaid direct. But it is important to underscore that people who are dually eligible will not transition into the standard plan option on July 1st.
Thank you for answering that. Sherry, I'm looking at the chat too. Are you seeing, there is another question. Please clarify if a child is in foster care when they transfer to standard plan, I guess, please clarify, I guess, what would happen with them in terms of,
Absolutely. No, and really glad to have the question asked. So foster kids who are enrolled in the foster care system will, and have the Medicaid evidence of foster care, will not transition into the standard plan option on July 1st. They are also part of that kind of sizable minority population that will continue to receive services as they do now. I do want to make sure to note one other detail about the foster care kiddos. After July 1st, we can all appreciate that there will be scenarios where a standard plan child has to enroll in the foster care program through a series of unfortunate events. That child needs foster care supports. We are working very closely with our partners, our standard health plan partners, and CCNC and our LMEMCOs to ensure that once a child is identified as being foster care enrolled, that that child is supported to effectively transition back to Medicaid Direct. So just wanted to acknowledge that once that Medicaid foster care evidence is reflected, that child will disenroll from the standard plan and return to the Medicaid Direct space. Good question.
Excellent. Okay, I don't see any other questions coming in right now. I think we've got everything. So if there are any additional questions, please put them in the chat right now, since we do have a few minutes left here. Just want to see if there's anything else. I think we're good.
Awesome. All right. Well, again, thanks for your collaboration today, and look forward to our continued work together.
Thank you so much. We appreciate your time. Thank you, everybody.
Bye-bye.